I'm a registered nurse, and I'm the Vice President of Clinical Services and the Chief Nursing Officer at the hospital, and so we're really glad to have you. I hope we went and gave you all literature. If not, just we'll help you out at the little table here then when you get done so you get the right information. This is actually, Sam's going to talk to you a little bit more later about our learning sessions, but today this is an educational session for you. And today our topic then is orthopedics, and we're very pleased and happy to be able to have Dr. Dean, our orthopedic surgeon, with us and to provide services to you in the community. And so he's our first presenter, and so he's going to share some information with you, and he's got a little presentation, and then we're going to do some question and answers. So it's pretty informal, and so we'll kind of get started. So this is Dr. Micheal Dean, and Dr. Dean has been with us since October 1st. He's located out in our temporary little clinic out on the grounds here, and if you didn't see it when you came in, when you walk out the door, just look to your right and you'll see the temporary building there. We are working to add a medical office building onto the hospital, and that's where we'll have our clinic, and Dr. Dean will have his practice there, and we look forward to having that within the, completed within the next year sometime. So for now we have the nice temporary location, so that's where that will be. So we'll let Dr. Dean visit with you then, so. Okay.
Thank you, Cindy. Thanks for coming out on a blustery day. Certainly a change in the weather. I've got a real basic talk, and it just has some basic definitions about what arthritis is in the hip and the knee. And I'll go through the talk, and you can stop me and ask questions if you wish. Real informal. And then at the end of the talk, I'd be happy to go over any questions that you might have that pertain to whatever your interest. I'm going to talk a little bit about hip and knee replacement today, and hip arthritis and knee arthritis, and I have to thank Larry Gerritsen who provided these slides from Biomed. Today we'll talk about anatomy, basic anatomy, nothing too scary or complex, what arthritis is, what the signs and symptoms of arthritis are, and what can be done to treat these problems. When we talk about the hip, we're talking about the ball and socket joint of the hip. And the problem that arises is wear and tear on the ball or in the socket of the smooth cartilage that just starts to go bad, kind of like a tire on a rim. The tire protects the rim from the road, but when the cartilage goes bad, basically the tire is bad, and then the rim is on the road and sparks start to fly. So the hip consists of a socket in the pelvis here, the acetabulum, and the femur. The very top portion of the femur is the hip joint. And here it is named, acetabulum and femoral head, basic stuff. What it does is hip cartilage covers the bone with the protective coating that also provides lubrication, a small amount of fluid is generated in every joint to allow for lubrication, allow cartilage to slide on cartilage without friction. And this is what protects our joints from wearing out. But some of us, of course, genetically or through accident or injury, develop arthritis in the joint, and that's kind of what we're here to talk about today. And the knee joint is a hinge joint as opposed to the ball and socket of the hip, so it tends to have just one planar motion, flexion and extension, consisting of the femur, thigh bone, the leg bone, or the tibia, and the patella, and the connection in between here where this cartilage surface is. It's if you look at it from the side, it's kind of like a rounded cam, and it provides the hinge movement and these runners of the cam on the inside and outside of the knee and behind the kneecap. Those are the particular areas that go bad when a knee wears out. Helps to distribute the weight of the body across the joint, so not too much weight is on one portion of the joint or the other. Again, knee cartilage is the protective coating, the tire, if you will, on the rim, and it provides a lubricating tissue, just like the hip joint, and a smooth gliding surface, so we don't feel any grit or grind when it's in a normal situation. Now, what is arthritis? Well, arthritis is defined as inflammation of the joint, if you look at the Latin, but it's the number one cause of disability in the United States. There's more than 100 different kinds of arthritis, but I'll talk about the two primary types, which are rheumatoid and osteoarthritis. And osteoarthritis is the most common form. If we look at an arthritic hip joint, what we start to see, instead of that smooth cartilage situation, we see erosion of the cartilage. We see bone starting to poke through the surface where we shouldn't see that. It's normally covered with a coating. And then we also form spurs around the edge of the joint in response to bone rubbing on bone. It'll actually create like a spur formation or extra bone to try and create more surface area to protect the joint. So we often we'll get spurs around our knee joints and our hip joints when they start to wear out. In a similar fashion, you see the knee joint has got worn cartilage here down to bone and spurs forming on the periphery of the joint. Rheumatoid arthritis is an autoimmune disorder where the body attacks itself. It attacks the joint, and joints specifically can affect hands very commonly, but can also affect the shoulders, knees, hips. It creates, the body just identifies cartilage as something bad and attacks it like it would attack a virus or a bacteria. And so it eats, essentially the body eats up the cartilage with its own immune defenses. And thus, you get a swollen joint, very painful, and this can occur in very young people, like with juvenile rheumatoid arthritis. You can even see it in young kids. It can be severely disabling, especially when it happens in a young person. Osteoarthritis is more of the wear and tear type arthritis. There may be somewhat of a genetic base to it, that some of us are sort of born with Michelin tires and some of us are born with not so good tires. And as time passes, those tires wear out. It's the most common form of arthritis, basically a wear and tear condition, and it develops over time. Overuse, injury, or repetitive movement can add to arthritis or create it. And there are certain developmental or congenital disorders which can create arthritis in particular joints. And this results in pain and stiffness of the joint. So the symptoms of arthritis are pain. This is the number one problem that creates loss of ability to do things. Stiffness of the joint can occur. Patients will note grating or catching or grinding like gravel sensation within their joint. And sometimes bony growths at the margin of the joint will affect the range, and those are called spurs, like I talked about. To get a proper diagnosis, normally you need to see a physician or a physician's assistant and have a full medical history to go over, how the pain occurs, why it occurs, what contributes to the pain, and then normally a physical examination, looking at the joint, looking at the range of motion, where it's tender along the joint line, or if there's deformity. Sometimes you see people with bowed legs. Sometimes you see people with real knock-kneed legs due to knee arthritis and that particular pattern of arthritis that forms. And then x-rays are usually all that's necessary to make the diagnosis, just plain x-rays. Sometimes MRI can be helpful, or bone scan. Conservative treatment of arthritis of the hip and knee specifically, we can make lifestyle changes. That is, we stop playing basketball or we stop doing particular activities that, would make it worse. We can lose weight. Definitely if you're, 350 pounds and you lost 100 pounds, it would put less stress on a bad knee or a bad hip. Exercise, to an extent, it's kind of a plus-minus thing. It's kind of like if the car's got a bad tire and it's almost down to the rim, if you leave the car in the driveway, it probably will do fine. But if you start driving the car, bad things might happen. There are some benefits to exercise before, if you're going to have a knee replacement or hip replacement, to build up strength and get you used to the exercises. But I'm a little bit dubious, and especially weight-bearing exercises for hip and knee arthritis, probably not going to help a lot. Medications such as anti-inflammatory drugs like Motrin, ibuprofen, or there's a myriad of different kinds of drugs that you can use that are like that. But Motrin and ibuprofen or aspirin are the cheapest ones. There are supplements out there, and there's lots of people that claim that they can cure arthritis or make it go away with various supplements like chondroitin and some of the other things that are offered out there. There's not a lot of science behind that, so I don't know really how to, some people tell me it helps, so I don't argue with them. If it helps them, fine. I don't think it will hurt you, except your wallet, maybe. There's rest and ice can help. Icing down a sore knee to reduce swelling can be quite beneficial. Physical therapy can be beneficial, and kind of like an outline of exercise. When to consider a joint replacement? Well, people that are at that point are generally coming in and telling me, I can't walk a block. I can't walk 2 blocks. I can't do my normal activities every day. My leg gets in the way of what I want to do. Those are the kind of folks that are coming to talk to us. And what they experience is a diminished quality of life. They just can't have any fun anymore, can't do their activities of normal living, take care of their house, take care of their chores. Conservative treatments, are tried and failed. These people, have had treatment with maybe cortisone shots, or there are some lubricating shots that can be given to treat arthritis of the knee, for example, and those are starting to not work anymore. Basically you have to every case is individual. You have to talk with the patient and hear their story and hear how much they're suffering and what they've tried to treat it before you can make a decision to go ahead with a joint replacement. The goal of the joint replacement is to improve quality of life, get rid of the pain, allow the person to be active, mobile, and it probably, it's been studied by, actually the government did a huge study looking at how hip and knee replacement improve quality of life, and it's probably the best thing that we do in surgery for getting people back to normal life, even better than it was compared to coronary artery bypass surgery. So it's a pretty good, reliable type of procedure to get people back to normal life. The value of a joint replacement, I guess they've done a study to look at this to see how much money can be saved if one has a joint replacement done in a timely fashion. And they in this study they suggested that there could be quite a bit of medical savings and cost savings to do a joint instead of waiting till, you just can't absolutely, some people wait too long, then they end up in a wheelchair. Other medical problems will happen. So there is some thought and some studies that show that perhaps there's benefit to thinking about joint replacement a little earlier if you're really limited in your ability to get around. Every year over 1 million people in the United States have joint replacements if you count hips, knees, shoulders. And joint replacement treats debilitating pain and deformity from various forms of arthritis. These are the primary components of a hip replacement. Basically, the acetabulum is resurfaced, the socket is resurfaced with a metal shell. Now that metal shell may or may not have a liner or plastic within it. There are other designs such as metal, just pure metal shells where you have a metal on metal articulation. The head is usually either cobalt chrome or a metal alloy. There are some other ceramics that are utilized that are very low, very slippery, so those are utilized, and there are some joints out there where they use just metal for the ball and metal on the socket. And the ball is attached to a stem that's actually down the marrow cavity. The marrow cavity of the femur is machined essentially with tools that open up the cavity and allow the bone to accept that stem, if you will, or this pin, so it's very solidly pushed into the bone, and it's got excellent stability in the bone immediately. That's just like you machine the bone out, and then this pin is sized exactly to what you've machined, and so when it's put into the bone, it's actually hammered into the bone, and is very tough and very durable right from the get-go. A knee replacement consists of 4 parts. The end of the femur, which is like a cap put on the end of the femur. You just remove a thin bit of bone and cartilage that's worn away on the end of the thigh bone. And in the same fashion at the end of the leg bone, metal and cartilage, worn out cartilage is removed from the proximal aspect of the tibia, and then it's resurfaced with these metal caps. And then in between the metal caps is a liner of very heavy duty plastic. that's got very good wear characteristics, made of polyethylene. On the back of the kneecap, normally we would put a plastic button, and the surface of the kneecap on the posterior aspect of the back of the kneecap is a joint surface, and that often will wear out too. So you need to replace that in many cases with a plastic button so that won't continue to hurt. What are the potential worries of joint replacement? This is what I talk about with everyone when I'm talking about doing a joint replacement. We talk about the risk of infection. Now, infection rates are very low, 1 to 2%, so 98, 99% of folks never have this. But if a joint replacement gets infected, it might require removal of the joint replacement, and then usually a treatment of antibiotics for a month or so, sometimes longer. And then normally you could put a new knee or hip back in after that. So it is a big deal if it happens. Nowadays we usually treat infection by putting a temporary knee or hip replacement in, made of antibiotic impregnated cement. And that allows the antibiotics to leach into the surrounding tissue and get rid of infection. So it's not like we put people in bed after they've had an infection. They're still able to get up and move, but it requires a couple of surgeries to repair if you ever do get an infection. Fortunately, it's rare. Blood clots are a big concern, especially in hip replacement, but also knee replacement. So most everyone, I think in the United States that has hip or knee replacement has some type of anticoagulation afterwards to prevent clots, because the risk of a clot, propagating into your lungs is the concern. And that could be fatal if it happens. So the risk is so high that most surgeons would treat with like Coumadin or Lovenox or some similar medication to prevent clots from ever forming. Implants can break. Over time, anything you put in the human body can break. Generally though, most implants that are utilized today, if they're put in correctly, they're very durable and will last 15 to 20 years. If a hip or a knee is put in crooked, it'll cause things to wear prematurely, or it'll cause the implant to break. So malalignment and wear is always a concern, and that's why we try to strive to try to get things in as square and straight as possible. Loosening over time can occur with a hip or a knee or a shoulder. And what happens is, like anything, a machine is put in the body, it may start to wear loose or come loose from the bone. And if that happens, then some folks have to have revision surgery where they actually would have another joint put in to fix that problem. In hip and shoulder replacement, dislocation can occur. This is where the ball can pop out of the socket. The rate of that happening is quite low, but it's a big problem when it does happen. Probably 1 to 2% of hip replacements will dislocate in their lifetime. And shoulder replacement, it's even less common, but it does occur. This is where the ball actually pops out of the socket. The message is here, no implant lasts forever, and anyone that states that they've got this knee or hip that'll last forever is not right. It's a machine, and a machine in the human body will wear. So it's important, I think, to stay kind of close to your orthopedic surgeon, and if you've had a joint replacement, and you start to develop pain, say 10 years, 12 years, 15 years down the road, you should see your doctor and have him check it to make sure that you're not getting these problems of wear or loosening. Various factors can affect the longevity of the joint, and things that I would attribute to what would make a joint replacement fail earlier would be very young age. Young people are much more active, so if they tended to run on a hip replacement, like Bo Jackson did, his hip only lasted a couple of years after he had hip surgery. So if they're real heavy, it can affect how long a hip or joint replacement lasts. So these are things that can affect the durability. And there's more information here at Biomet. They have a huge resource section for patients if you're interested.
When we talking about the blood clots and blood thinner, is that a temporary thing until things are squared away?
Usually.
It's not a lifetime thing?
No, sir. Usually anywhere from 2 to 4 weeks post-op, a patient would be treated, unless there's a special condition where they have a,
Right, but it's not a lifetime.
if you've had a clot before, and do a complete medical workup, just to avoid problems. You know, you'd be surprised how many people have hidden cardiac problems. They don't know it. And if we didn't work it up, they could get into big trouble if they had surgery. So that's a key issue, is to see your primary care physician. We usually arrange that if I talk to anyone about having surgery. Dental workup, you know, we like to see people make sure that there's no abscess teeth or infections in their mouth, because that can spread to a joint replacement. So that's pretty critical to get that under control. Make sure you don't have any, you know, festering problems, literally, within your mouth. We prepare the home to assist in recovery. Usually this is done with social services and physical therapy. You'll kind of look at your home environment, make sure everything is safe for you to go home, make sure you have adequate tools to get better, and kind of have to follow what the doctor says to get better, of course. Follow-up visits. Normally I see folks after a joint replacement at 2 weeks, 4 to 6 weeks, and then 3 months, and then as necessary, depending on the patient's problem, you know, after that. But most folks by 3 months would be pretty well healed and on to their normal life and getting on with normal activities. It is, I think, helpful to see an orthopedic surgeon. You know, if I have any worries about, say it's a real heavy patient, or I know it's a real young or active patient, I'll want to see them more frequently to just check an x-ray, make sure they're not developing any wear and tear. Older folks, you know, as long as they're behaving and, you know, not doing too much that out of bounds, like running, jumping, heavy lifting, they can usually go 5 years between checkups. Or if anybody develops pain, of course, then they need to be seen right away. In closing, a proper diagnosis is necessary from an orthopedic surgeon to help identify the cause of your pain. Sometimes spine problems can mask as hip arthritis, very common. People think they have hip disease, and they come in and see me, and it's all in their spine. So it's really important to get a history, a physical, x-rays, and a complete workup to answer your questions. There are many conservative treatments. Cortisone injections, Synvisc, or lubricating injections are quite helpful. Anti-inflammatory medicines, therapy, these things can all be tried. And arthritis, the bottom line of the whole talk is that arthritis is a treatable problem nowadays, and you know, there's no reason to let it sit and let it put you in a wheelchair, or let it put you, you know, at a point where you're just not having any fun with life. And thank you. Be happy to answer any questions. Or
How long do they usually stay in the hospital?
most folks, assuming, you know, they're healthy and there's no serious issues, 3 days, 3 to 4 days.
So there's cartilage in the bone, and you said you put a rod or something down in the bone to stay in. I mean, not cartilage. There's bone marrow.
There is.
So does that get hollowed out then when you put that?
It does, yeah.
Okay.
In the adult, like a hip, in an adult, that marrow is not really producing a lot of blood components.
Oh, okay.
Most of the blood components in the adult is produced in the pelvis, and there's a lot of surface area within there to do that, also in the spine. So hollowing out that marrow cavity doesn't seem to have any issue as far as, you know, producing blood cells. Okay.
You have the model up there too, if you
Yeah.
want to.
Why don't we pass this around? This is a knee. That's what a knee replacement looks like. The clear plastic is what the bone is, and then this is a hip replacement.
Now, do you do the hip from the front or the back?
I do posterior approach. I've trained on the anterior approach. Both are good, viable approaches. I think I get a little worried when people say that the anterior approach will make people better immediately. That's not really very realistic. You're still doing the same thing to the bone. You're still, you know, opening up the bone cavity, dislocating the hip, for example. And so to say that you're going to be better in 3 to 4 weeks is really quite extreme. I think, you know, but both approaches are viable, good ways to do the hip surgery.
But you do the back maneuvers, is that right?
That's what I trained with, and I think, you know, you want to go with a surgeon that, you know, kind of is comfortable with the approach he uses.
Because everybody's talking the front, you know.
Right. There's a lot of marketing out there.
Yeah. got a couple friends that had it done, and gee, within a month, they didn't have a cane, you know, they were just out shopping and doing great.
Do you want to talk about that, how long they use a cane and how long
Sure.
they?
Most folks with hip replacement would use a walker for, up to a week or two, and then a cane for a couple weeks. So by a month, most folks are starting to rid themselves of their cane. And, by 4 to 8 weeks, people are pretty happy usually with hip replacement, regardless of the approach. There are people that take longer, usually folks that are older. So, like I said, the approach to the hip is not critical. What's critical is how the implant is put in. Is it straight, square, and aligned properly? And that's what's going to make a hip implant last long and not, dislocate or pop out of the socket or wear out prematurely. It's really what you want to see is you want to have a hip that lasts you 15 years.
And how long do you have to go for physical therapy after you have it?
Usually therapy starts in the hospital. You'll get visits usually a couple times a day. And we'll have you up walking up to full weight bearing on the leg right away for a hip or a knee. And then after you leave the hospital, we usually will have therapy come to the house for a while, home physical therapy for a couple weeks. And then after that, if people need more therapy, we can have them seen in the outpatient setting. Knees tend to need a little bit more therapy than hips do. So a lot of folks with hip replacement, after a couple weeks, I just tell them to walk, and that generally, is all they need to do. But knees may need up to 6 weeks of some physical therapy.
And what we do in the hospital is we start doing discharge planning from the time when you first come into the hospital. So you'll notice that you would have the social worker, the charge nurse, they all come in and they kind of work on a plan of discharge for you. They bring in the physical therapist, bring in the home health nursing staff, and we look at what's best for you when you go home. Sometimes some people can't go home right away. Afterwards, they don't have support at home, they don't have the home set up, they don't have anyone to help them. You might have someone who has a little bit more problems, need a little bit more assistance for longer than your normal hospital stay would be. So we do look at a short-term swing bed, which it's just a different kind of payment status. It's not a regular hospital stay, but it's staying in a more of a short-term, long-term stay. You could stay a week or two until you feel a little stronger, ready to go home. We allow that kind of a stay up in the hospital, and we look to see if that might be something you need. We look to see if you will be staying at home and if it's appropriate for the home health nurses and therapists to come and see you. Or if you're doing really well, or you might be a real younger person who is able to get out and about more, you might even come in and have your therapy here in the hospital in the physical therapy department. So there's a whole group of people that work with you, with your doctor, and trying to figure out and make sure that you have what you need and what works best for each individual person when you go home. Okay.
Sir?
I don't know if you can back up slides, but I was curious to know when a hip breaks, where does it break?
It can break in a number of places.
Oh, okay. Well, I just thought there might be a kind of common.
Let's see here. Go too far back. Hips can break, there are some design problems that occurred in earlier hips where they would break here at the trunnion, where it connects to the ball. But I've seen them break down here on the stem too. It kind of depends on the individual situation and the biomechanics and how that hip is put in. If there's something a little off, or you haven't allowed for the proper physics to occur of how the muscles relate to the joint.
Well, I'm talking about before you ever do this.
Oh,
Just,
well, how can a
What-
hip
what-
joint break?
well,
like when people
where does
fall.
it break?
Broken
and
hip,
then
yeah,
you
okay.
put a new one in.
Sorry. Oops, now I did it. All right. Here we go. Well, normally a hip would break, there are a couple of patterns. Oh. Can you go to like this, the normal anatomy one? There you go. Good, perfect. You'll see cracks of the femoral neck. this is one that normally would require hip replacement if it's significantly knocked off. If you know, you just have a non-displaced crack, a lot of patients, we could put some screws across that and fix it. And that, you know, you keep your own parts, which is obviously not a bad thing as long as the hip joint's not already worn out. But if a crack occurs here at the neck of the femur and the ball displaces from the shaft, then normally we'd put a hip replacement in for that. Another pattern we often see is a crack between the trochanters. This is the greater trochanter and this is the lesser. And it will crack right across. They're called an intertrochanteric fracture. That normally would be fixed with either a rod down the thigh bone with screws across, or a plate applied to the side of the thigh bone with a big screw that goes into the center of the ball. And there are other cracks that can occur below the trochanters called subtrochanteric fractures that often require a rod down the femur to fix. Those are the three most common. Sir?
I have cortisone shots put in mine last for a while, but not very long, about a month or so. My left.
Yeah, you know, cortisone can last a month, 2 months, 3 months, sometimes longer, depends. The more shots you have, I think, the less effective it starts to become. I use it a lot, though, for folks that have early arthritis or can't have surgery. It can be helpful.
Rheumatoid arthritis too with that.
Sure. So, yeah, it's certainly a legitimate thing to do.
Is
Yeah.
it- Oh, pardon me.
Go ahead. Well, the other injections that are given are the lubricating injections, which are a little bit more expensive, but can be quite helpful. And it's the same technique as you had with your cortisone shot.
What other injections can you provide? I mean, can
How long
be
would
put
those
in.
other ones last?
What was that? I'm sorry.
What other injections?
Well, there are medicines called Synvisc, or there's 3 or 4 different medication preparations that are a similar drug that can be injected in the knee joint in the same technique that you had with your cortisone injection. Usually it's a series of 3 injections over 3 weeks. There are some medicines out there where it's just 1 injection. You know, you just get 1 and done. And those can last up to 6 months, is what companies will often advertise.
I'll have to come and see you sometime.
Okay.
I've had the Synvisc now in both my knees for 5 years.
Yeah,
Yeah, and they look good for me.
there are a lot of folks like that
But-
have the same, they just keep coming in for Synvisc and they're happy that way.
But if your insurance doesn't
Does
pay,
Synvisc work real good?
Synvisc is a good, I think it's the only one out there where it's 1 shot, so you don't have to make 3 trips to the doctor. I've found it to be pretty effective, yeah. And you do have to pre-approve it with insurance. You can't just have it when you show up. The insurance companies, it's quite expensive, so but normally it gets okayed every time. And
but if you have to have it more than once a year, then they're real sticky on it.
well, every 6 months is what I've found.
The last time I had it,
Yeah,
it was hard to get them to pay, and
they usually, most insurances will pay for it every 6 months. That's what I've found.
And
what does
there's
that mean,
nothing to-
lubricate?
It's a fluid that's kind of like joint fluid. It's actually synthesized from the comb of a rooster.
Oh,
Some people call them rooster shots.
oh,
So, and it's very similar to joint fluid. Somehow it will lubricate the joint like joint fluid does, and it also may cause the joint cells to make more fluid to help lubricate the joint. So that's how they think it works.
I have mine x-rayed. They say it's rubbing bone on bone already.
Yeah.
So
Mhm.
it wouldn't be no good to have.
Well, you know, there are a lot of people that come in and have shots that helps with bone on bone.
Yeah.
So,
Okay.
you know, there's no reason to just jump into a joint replacement if you haven't tried the lubricating shots.
Injections.
Yep.
Okay.
Ma'am.
Well, anybody that I've ever talked to says that there's a lot of, you get 1 series of shots or whatever, and the second time there's a lot of danger of being allergic to it, or.
It can happen. Some of the drugs do get allergic reactions where you get almost like the knee is acting like it's infected. But that's quite rare.
Really?
Yes, that may have gotten overplayed with your situation there. I've given Synvisc shots to multiple times to patients over years and never had that issue. Now, I've had some people get reactions too, but they're pretty few and far between.
So you could go, because I guess what I was told was that would be, I've had two, excuse me, steroid shots.
Mm-hmm.
The first one lasted better than a year, and the second one has only lasted about 2 months, 2.5 months.
Yeah, that's not an uncommon scenario.
But he says he gets a shot every month, is that?
That's kind of a little too much. With steroid shots, I only like to do them once, 2-3 times a year at the most. Every month you'll actually cause some damage to the tissues if you inject cortisone every month.
It lowers your immune system too, doesn't it?
It may lower your immune system. It may cause problems with the adrenal glands. It may cause, some weight gain. It could cause diabetic problems. Repetitive steroid intake is never a good thing if you can avoid it. But a shot once or twice a year is fine. More than that, I think, is kind of getting a little out of bounds.
But the Synvisc, you can have, she said 5 years?
Oh, yeah.
I've had it
Yeah.
every year for 5 years.
Yeah.
What would be the downside on the chicken shot?
It just costs a little bit more, but usually insurance will cover it. The downside, there's very little downside to it. So,
Well, I was told that I could use steroid as long as it had a long-acting effect, and then go to the Synvisc, because you can have surgery. You can't have surgery for 6 months after a steroid shot, but you could have surgery after a Synvisc shot.
no, I don't know. I don't know about that. You can have surgery after a steroid shot. I normally wouldn't give a steroid shot a few weeks before a surgery, but a month later, no problem. So I don't know. You
But
might
it
be.
sounded like the Synvisc was the last ditch just before surgery.
No. I wouldn't treat it that way at all. I'd use it more. If say a cortisone shot didn't work right away, or you didn't get a very long response, then I would try Synvisc. The reason I try the cortisone first is it's cheaper, and the Synvisc you've got to go through some hoops to get it done. But usually insurance will cover it, and it can be a way to prevent surgery for quite a while.
Does Medicare cover?
I had Synvisc put in there for a while. It lasted quite a while, and then after that, they put cortisone shots in
Mm-hmm.
to help me along. So.
Yep. It's a way to prevent surgery for a while.
Do you ever use a human knee for a knee replacement?
The human knee.
Yes.
There are times when you'll use what we call allograft or human tissue to replace certain parts. Like if there's a situation where you're in a revision surgery, redoing a knee that's already been done once, and there's bone deficiency, then you may need to use some bone to fill up. And that in particular in the hip joint, that's pretty common. The knee, not quite as common, but it can happen.
'Cause my niece just had surgery done and she had a man's knee
Well,
put in. Because they say that's stronger.
I am not
They told her it was
sure
stronger.
entirely what they did there, but.
I don't either. That's why I was asking you.
Well, man's knee, no one ever tells me the sex of the bone that so I just get it from the tissue bank and use it for the surgery, so I'm not quite
I'll have to ask
certain
her.
what happened.
So have they done like studies like a stem cell? I know that's down the road, but to regenerate the
Yeah,
knee and stuff like that?
there are things being done with genetic research to try and treat arthritis. May put joint surgeons out of business someday. I don't think we're that smart yet, though. We haven't gotten to the point where we have an applied treatment that we can give to patients that can produce normal cartilage again. There are some things that you can do to treat small injuries or defects in the knee or hip with cloning cartilage, and then for someone who has an arthritic joint where the whole thing is starting to come apart, those kind of cloning treatments where they clone cartilage and put it in there, it doesn't work. It's just too big of a problem.
Talk a little bit about what I've heard, procedure where you go in and maybe remove some cartilage that has come loose and it's floating around in there and causing friction, and you
Sure.
just kind of clean up the joint.
Yeah, that's arthroscopy. Knee arthroscopy is probably the most common surgery orthopedic surgeons do. It's usually done to correct a torn meniscus or a torn pad between the bones. Those meniscus are like rubbery disc in the knee, and they provide shock absorption and support. And the disc will tear sometimes and fragment, and pieces of it will flick back and forth in the joint, causing mechanical symptoms. So you can look in the joint with a fiber optic camera and introduce some small tools to either trim out that damaged area or fix it with stitches. Generally, those are people that don't have much arthritis problem though. The coating on the bone is still good. So it's a treatment utilized in folks that are younger, that don't have a lot of wear and tear, or just people that don't have a lot of wear and
And
tear.
the x-rays will tell you whether or not that's what you need or not. Or
Yeah, normally for, if I had a torn cartilage, the x-ray won't show much. It'll just show a normal looking knee. So you have to get an MRI to find it, because it's a soft tissue injury. The MRI would show that a little bit better. People with a worn out knee or an osteoarthritic knee, that cartilage is already gone. It's wore away. So they're really far down the road. Sir?
The procedure for the, I call it the chicken shot. Is that similar to the cortisone thing, just come in the office and
Yep, exactly the same. So not a big deal. You get a numbing, lidocaine shot, and then numb area there, you inject the Synvisc into the knee joint through that numb area.
and that works if we have bone on bone?
It can help, yep. Some cases it won't, but it's certainly worth a try. You don't burn any bridges by having a shot.
How soon can you tell whether
I'd say within a couple, 3 weeks, you should know. If by 3 weeks you're not feeling somewhat better, then it didn't work. Anything else?
What are the types of general procedures do you do? I don't know if you want to hit on that a little bit.
Myself?
Yeah.
Hip, knee, shoulder replacement, knee arthroscopy, ACL, ligament reconstruction, fracture work, carpal tunnel surgery, trigger fingers, basic hand fractures, general orthopedics. So, everyday stuff.
Yeah.
when you say trigger finger,
Sir?
when you say trigger finger, you're talking, there's two kinds of trigger fingers, is there not? One that catches,
Mm-hmm.
and then the other one is like that?
Well-
You have to replace the tendons?
Generally, a trigger finger is where a nodule forms in the flexor tendon. And this, the tendon that pulls your finger into flexion. And that nodule will get caught in one of the small pulleys of the
Then you have
hand.
to pull them up.
And so when it gets caught, it'll click and actually get caught.
Yeah, but
And
what do you call this?
you're starting to get a contracture of your joint there, I think, from arthritic change.
It was the tendons first.
Oh, you may have, yeah, I guess I better examine you before I tell you. Trigger fingers are specifically fingers.
Couldn't get them back up at all.
Well, you could put them up if they wouldn't stay.
Well,
He said they replaced the tendons,
Oh.
tendons over.
Do you do that kind of surgery?
I don't do a lot of tendon transfer or tendon repairs because that's usually a hand surgeon that will do that. It's more complex. But basic hand surgery like a trigger finger is really pretty simple surgery, or carpal tunnel, or hand fractures.
With carpal tunnel, you just don't get out of it.
I'm sorry, sir?
Well, what do you do for carpal tunnel?
Carpal tunnel is like when the median nerve, the big nerve in the hand, starts to get compressed at the level of the carpal canal. There's a big ligament that crosses the nerve there, and over time that ligament may cause some pressure on the nerve. So the nerve doesn't get proper blood supply.
So does that make the whole wrist hurt?
It can make your wrist hurt, but more commonly it'll make these fingers hurt and numb. the thumb, the index, long, and part of your ring finger will get numb. And when you try to read a book or drive a car, your hands will go to sleep. Or you wake up at night, your hands will go to sleep. That's carpal tunnel. Okay.
How often does therapy cure that?
Therapy for carpal tunnel, usually we try treating with splints to put it rest,
Yeah.
or we'll inject cortisone
Uh-huh.
around the nerve. And if those things didn't work, then you're really having trouble, then the next step is to think about joint replacement.
Going upstairs is terrible,
Yeah,
every step.
yep. Sir?
Is there a difference between joint replacement and complete knee replacement or hip replacement?
There's a whole lot of varieties of joint replacements. Basically, joint replacement means to resurface all or portion of the joint with metal and plastic parts. Like in the knee, there are hemiarthroplasties where you do just a portion of the knee. You know, like one of the runners is replaced instead of the whole thing. In the hip, you can do resurfacing where just the ball, the covering of the ball is replaced instead of putting a pin down the thigh bone. So there's a variety of different operations out there that accomplish the same solutions to the same problems.
Can you tell what you're gonna do by an x-ray? Or?
Yes, your doctor should know exactly what the plan is from x-ray. Occasionally MRI or bone scan can be helpful for cases that aren't clear on x-ray, but most people with arthritis in the knee or hip that are going to have surgery, a plain x-ray is all that's necessary.
Does Medicare pay for an MRI?
Oh yeah,
They do.
yeah, if the doctor thinks it's necessary. Mm-hmm.
Okay.
Sir?
Do you do MRIs before you do the chicken bone?
No, not normally. There are cases where I have, but normally if I look at a patient and get an x-ray and I see their knee is wearing, then I don't need to spend that money on the MRI because I already know what's going on. So the vast majority of folks, just an x-ray will tell me.
If you get old x-rays, past x-rays, does
Yeah.
that help you with that?
It can. Generally, if you want me to give you an opinion, though, relying on information that may be 6 months old is not so helpful. I know a lot of folks come in and they want me to give them a diagnosis and don't take another x-ray. Well, you know, things change in the course of 6 months or 4 months, so probably it's best to have up-to-date information.
We have time for about one more question. Anything else?
I'll ask a question. People talk about crossing your legs or not crossing as far as how it
Mm-hmm.
messes with your joints. Does that actually, is there really something to that?
Well, as far as causing trouble in a normal patient, no.
Mm-hmm.
But crossing the legs in a patient who's had hip surgery, we tend to discourage that because it can cause the ball to get in a position where it could pop out.
Oh, okay.
You know, crossing your ankles is fine, but crossing your knees, like a lot of ladies like to do, is it tends to put the hip in a bad position. So a lot of hip surgeons give instructions to their patients, don't do that. Because you cause gray hairs on their head if you do that.
Okay.
Well, thank you, Dr. Dean.
Thanks.
We appreciate it.
Yep.
Thank you all
Thanks
so
for
much for
listening.
coming.
Thank you.
You'll find a small survey that's sitting right in front of you. You can fill that out for us. That would be great, and just leave it on the table. We'll pick them up afterwards. There is a front and back to it, so if you could please fill out both. If you would like us to contact you for any reason, if you have any additional questions, please write your name and a contact on their email or number, and we will get back to you. So we will be holding monthly educational series, so it will be called JRMC U. So keep an eye out in the newspaper and online, or you can just call in and ask, and we'll have it scheduled here if you have any questions on future ones. The topics will vary from microbiology to family birthplace to simple things as cold and flu. So just keep an eye out. Next month is American Heart Month, so we'll probably do something in relation to that. So we'd like to thank you all for your time and hope to see you again.
And if you hadn't gotten a packet, stop up here. There's one specific to hip, there's one specific to knee, and also information in there. There's some information about Dr. Dean and the clinic, and there's actually the phone number and everything's in there, so if you decide that you want to come in and see Dr. Dean, you have a phone number and just information about him also. Okay? Thank you.